alpha, yeah, 2 alpha, 1 beta, 1 delta, and 1 epsilon subunits. So the acetylcholine, 2 molecules of acetylcholine are required to open the nicotinic acetylcholine receptor because both the alpha subunits have to be occupied by the acetylcholine molecules. Once 2 molecules of acetylcholine occupy the alpha 2 alpha subunits, the channel will open.
Yes.
That is, the receptor will open, which has got a central channel is there. It opens, and once it opens up, sodium enters inside, potassium will start coming out. And this produces an alteration in the transmembrane potential. That is what we call it as depolarization. A current is produced at the neuromuscular junction, and this current is voltage is transmitted all along the muscle membrane. So once it is transmitted all along the membrane, so this signal is taken inside the muscle cell through the transverse tubules. The voltage is taken inside the muscle cell through the transverse tubules. These transverse tubules, they open into the surface and they go into the cell proper, inside the cell proper. So once the signal enters the cell through the transverse tubules, so it activates the sarcoplasmic reticulum. And the sarcoplasmic reticulum will release, because sarcoplasmic reticulum will contain or sequester the calcium ions inside. So the calcium will be released by the sarcoplasmic reticulum inside the muscle cells. So this the calcium will go and bind to troponin. The troponin will be holding actin filaments from sliding over myosin filaments. So once the calcium goes and binds to troponin, so the actin filaments get released. They can easily slide over the myosin filaments. They just slide over the myosin filaments, and that's how the muscle contraction occurs. In the meantime, what is happening for the acetylcholine in the synapse and also the molecules of acetylcholine, they dissociate from the alpha subunits. And once they dissociate, what will happen is the acetylcholine is acted upon by acetylcholinesterase, or the true cholinesterase that is present in the synapse, and gets metabolized to acetic acid and choline. And this choline is taken back by the nerve ending again to produce acetylcholine there, to manufacture or synthesize acetylcholine. So the choline combines with acetyl coenzyme A that is released from the mitochondria there in the motor nerve ending. The combination of acetyl-CoA plus choline produces or synthesizes the acetylcholine, which is stored in the vesicles there. And acetylcholine, which is released in the synapse, also stimulates presynaptically one more nicotinic receptor, which is alpha 3 beta 2 receptors. This is called as presynaptic nicotinic receptors. Once this is stimulated, so it makes sure that whatever the immediately available acetylcholine vesicles which are released, now that they have to be again more amount of acetylcholine has to come and then replace this immediately available acetylcholine which has already been released from the reserve. So this activation of alpha 3 beta 2 receptors will make sure that the reserve from the reserve acetylcholine vesicles will move towards the active zones, and they are already there as immediately available acetylcholine for the next impulse. Whenever the next impulse comes, so these immediately available acetylcholine vesicles can open and then produce an active muscle contraction. So that's how the whole process occurs. And these calcium channels are voltage gated calcium channels. They are P channels, and they are not L channels. L channels are slow calcium channels. P channels are actually fast calcium channels. So it is very important that the calcium enters the presynaptic nerve ending. So by the entering calcium only, that the acetylcholine can be released. If calcium is not entering into the presynaptic nerve ending, then acetylcholine cannot be released. So this particular process is very, very important. Like I was telling you, that these calcium or channels can be destroyed in one of the syndromes, that is Eaton-Lambert syndrome. Yeah. In Eaton-Lambert syndrome, it's a presynaptic problem, unlike myasthenia gravis, which is a postsynaptic problem where the number of receptors are decreased by an autoimmune reaction. Here, the Eaton-Lambert syndrome, the presynaptic receptors are, block. Presynaptic calcium channels will be destroyed because of the malignancy. Majority of the times, it is secondary to malignancy, especially malignancy in the lung, which is very, very common, Eaton-Lambert syndrome. So pulmonary malignancies. So that's how, acetylcholine will not be released, and these patients will have muscle weakness, and especially the muscle weakness is more of proximal muscle weakness, unlike myasthenia gravis, which is the smaller muscles, the muscles of the eyes and smaller muscles of the hand that are involved in myasthenia gravis. And another important difference between Eaton-Lambert's and myasthenia gravis is more common in young females, whereas Eaton-Lambert's is more common in older males, where pulmonary malignancy is more common because of smoking. Cigarette smoking is one of the most common causes, and it takes some time. So usually these patients will be male patients, and usually majority of them are quite older patients. That is another important difference. And anticholinesterases will reverse myasthenia gravis and helps to improve the activity of the muscles, whereas in case of Eaton-Lambert, they may not help in improving the muscle weakness. And in myasthenia gravis, actually, the activity will produce actually more fatigue of the muscles of the myasthenia gravis, whereas in Eaton-Lambert's, activity will improve the muscle weakness. So these are some of the differences between Eaton-Lambert's and myasthenia gravis. Many times this can be asked for you in the exam. And again, the thymectomy may definitely improve the condition in myasthenia gravis, whereas the Eaton-Lambert's will not be helped by thymectomy. So some of the differences between Eaton-Lambert's and so in Eaton-Lambert syndrome, the calcium channels are involved. So that's how the problem is there. And another thing is, again, the magnesium can block these calcium channels, because magnesium is one of the commonly used drugs in case of preeclampsia, and especially preeclampsia with severe features. We always give magnesium sulfate as an infusion, and also a bolus of 2 grams plus, or bolus of 4 grams, and then every hourly 1 to 2 grams intravenously will be giving. So depending on whatever the intramuscular regime or Pritchard's regime or Zuspens regime or whatever the regime what we use, majority of the times we go for IV regime. So, but magnesium again can produce paralysis by itself by blocking the calcium channels, by blocking the release of acetylcholine. So that's how, these patients on magnesium sulfate, they are very sensitive to non-depolarizing muscle relaxants. So when a patient is on magnesium sulfate, especially for preeclampsia with severe features, and you have to give general anesthesia for these patients, it is very important to monitor the neuromuscular junction and then give the doses of non-depolarizers. Otherwise, there can be prolonged duration of action of non-depolarizing muscle relaxants because of effect of magnesium. So that is another important thing. One more thing about the calcium channels is especially the aminoglycoside antibiotics, like your amikacin, then gentamicin, then kanamycin. So all these aminoglycosides also block calcium channels. So by blocking the calcium channels, they can also prolong the duration of action of non-depolarizing muscle relaxants. So that's how the importance of these calcium channels. So as far as the anatomy of the motor nerve ending is concerned. So, and again, alpha-3, beta-2 receptors, presynaptic receptors are also important because they get blocked by non-depolarizing muscle relaxants. And that will prevent the reserve acetylcholine to move towards the immediately available acetylcholine. That's how you have what is, many times the action of non-depolarizers as far as your neuromuscular monitoring is concerned, because that will produce fading. isn't it? So these are some of the things about the anatomy and physiology of neuromuscular junction. I hope you have understood now troponin,
Yes, sir.
calcium releasing troponin
Yes,
from
sir.
actin filaments. So actin can slide over the troponin and can produce the neuromuscular muscular contraction. So any other doubts regarding the previous discussion, anatomy and physiology of muscular junction? Jasvi doesn't have any. No, everything is understood. Okay, so let us continue with today's discussion, and especially pharmacology of individual drugs. And we also said how to classify the neuromuscular blocking agents, basically classified as depolarizers and non-depolarizers. So examples for depolarizers were succinylcholine and decamethonium. And decamethonium is no more used because of histamine release reduced. So that is why we don't use. Only depolarizer, what we use is succinylmethonium or succinylcholine. Non-depolarizers are again can be subclassified as based on the structure, aminosterides and benzyl isoquinonium group of drugs, or based on their onset and duration of action. So we can classify them as, short-acting, intermediate-acting, and long-acting drugs, isn't it? So some of the examples for short-acting is mivacurium, and intermediate-acting is vecuronium and rocuronium, and also your atracurium and cisatracurium. And long-acting drugs like galamine triethiodide is there, and pancuronium, DTC is there. And there are other group of drugs like doxycurium, pipecuronium, which we are not using them. So coming to the depolarizing muscle relaxants. So we have to discuss about only succinylcholine, isn't it? So structurally, what is succinylcholine?
It's two molecules of acetylcholine that is combined.
Yes, very good. So it is actually the two molecules of acetylcholine. That is how, it also acts similar way like acetylcholine. So that is why it also produces depolarization at the neuromuscular junction of the motor end plate, just like acetylcholine, isn't it? So, but what is the difference between the effect of acetylcholine producing depolarization and the effect of succinylcholine producing depolarization and later paralysis? Acetylcholine will not produce paralysis, isn't it? Though it produces depolarization, but succinylcholine, because it has got two molecules of acetylcholine joined together, also produces depolarization, but later it produces paralysis. That's how it is a neuromuscular blocking agent. So what is the difference between the effect of acetylcholine and succinylcholine at the neuromuscular junction? Why succinylcholine produces paralysis? Why acetylcholine does not produce paralysis?
Causes hyperpolarization and desensitization.
Nothing called as hyperpolarization. I think you got back the
Yes.
power. Good.
Yes.
Very good. So nice. So how does succinylcholine produces paralysis?
Sir, it basically
It causes
it causes prolonged depolarization. That is what causes
very good. So
the muscle to contract, and that is how
no, it produces prolonged or
prolonged
depolarization.
sustained depolarization.
Why it produces sustained depolarization? Why not acetylcholine?
Because the diffusion of succinylcholine is more widespread than
No, how acetylcholine is metabolized and how succinylcholine is metabolized?
It is metabolized into
How acetylcholine is metabolized and how succinylcholine is metabolized? That is now you have the clue why it produces sustained depolarization.
the acetylcholine is
Why? How acetylcholine is metabolized? I just told you. How
Yes,
acetyl-
sir.
Acetic acid and choline, sir.
yeah, by acetylcholinesterase or otherwise called as a true cholinesterase.
true choline.
How succinylcholine is metabolized?
Pseudocholinesterase by
Pseudo-
pseudocholinesterase.
Is pseudocholinesterase present in the neuromuscular junction?
No, sir.
It is not present in the
Not
neuromuscular
present.
junction, isn't it? So succinylcholine cannot be metabolized at the neuromuscular junction, isn't it? It
Yes,
has
sir.
to enter into the plasma and then it has to get metabolized, isn't it? So that means it remains in the neuromuscular junction for a longer time, unlike acetylcholine. Because acetylcholine, it immediately gets metabolized because acetylcholinesterase is there in the synapse. Whereas there is no pseudocholinesterase or plasma cholinesterase or otherwise called as butyryl cholinesterase that is present in the synapse. It is not present in the synapse. It is only present in the plasma because it is synthesized by the liver. So succinylcholine has to come out of the neuromuscular junction. It has to come into the extracellular compartment and enters the plasma.
Plasma.
There only it has to get metabolized. Because of that, it remains in the neuromuscular junction for a long time.
For a long time.
It can remain in the neuromuscular junction in the long time. It associates, dissociates, and reassociates with the receptors and produces a prolonged depolarization or a sustained depolarization. And this sustained depolarization can produce paralysis. Now, another important thing here is how sustained depolarization. So initially, it produced depolarization. That is the reason why it produces muscle contractions. That is what we call it as fasciculations.
Fasciculations.
So acetylcholine will not produce fasciculation. It produces regular contraction. Whereas succinylcholine, because of its repeated activity on the neuromuscular junction and the nicotinic receptors, so initially it produces muscle contraction that is called as a fasciculations and later paralysis, isn't it? So why sustained depolarization has to produce paralysis? Now you know the basic difference between acetylcholine and succinylcholine. Now, succinylcholine, because it produces sustained depolarization, it produces paralysis. That's what we discussed. So
Yes.
sustained depolarization, what is the theory behind sustained depolarization producing paralysis? The theory is called as accommodation theory. What is this accommodation theory? It is beautifully given in older Miller editions. This accommodation theory. What is this? How does it sustained depolarization will produce paralysis? No, if you don't know, I'll just tell. No problem.
No, sir.
No, sir.
We don't
Yeah,
know.
okay. So what happens here is, so the depolarization that occur at the neuromuscular junction is transmitted to the extrajunctional place and then all along the muscle membrane. That is what already we said, isn't it? The voltage is transmitted all along the muscle membrane. In the muscle membrane, we have voltage-gated sodium channels. In the voltage-gated sodium channels in the muscle membrane, so there are two gates. The outer gate is called as a voltage gate or voltage-dependent gate. There is an inner gate in the channel which is called as a time gate. Outer voltage gate, inner time gate. So inner time gate will remain open as long as the voltage gate is closed. Now what happens whenever the depolarization occurs, the voltage gate opens in the sodium channel. Once the voltage gate opens, the time gate is already open. So now depolarization occurs all along the muscle membrane by sodium entering inside and potassium coming out. After a particular duration, the time gate closes. Again, if the time gate has to open, the voltage gate has to close. That is what occurs in normal contraction, acetylcholine, because acetylcholine gets metabolized After that, no voltage is transmitted all along the muscle membrane. The voltage gate closes, the time gate opens.
Opens.
That is how normally it occurs. Now, because there is a sustained depolarization, there is a continuous voltage going across the muscle membrane. So the voltage gate remains open of the muscle membrane, of the sodium channels. Once the voltage gate remain open, I told you after a brief time, the time gate inside is closed.
Closed.
And it will not open till the voltage gate closes. So what will happen now? No more entry of sodium inside or no more potassium can come out. So that's how, though there is a sustained depolarization, the muscle cannot contract, it will go for paralysis. And this is called as accommodation theory, which is an accepted theory of how succinylcholine produces, paralysis. Because of the sustained depolarization and sustained association with the nicotinic receptors at the neuromuscular junction, a continuous voltage is transmitted all along the muscle membrane. So the sodium channels, the voltage gate remain open. It cannot close because there is a continuous voltage is being passed, but the time gate has closed. So no more depolarization. So once there is no depolarization, the muscle will go for paralysis. And because there is still succinylcholine molecules are there at the nicotinic receptors, acetylcholine cannot act again. So that's how, there is the paralysis will continue. So this is what is, we call it as the accommodation theory. I hope you have understood.
Yes,
Just
sir.
about voltage gate and time gate. So the time gate will remain always open, but voltage gate remain closed. So whenever a current comes, the voltage gate opens, and that's how depolarization of the muscle membrane occurs. But after some time, the time gate closes. But again, for the time gate to open, the voltage gate has to close. But with succinylcholine, the voltage gate cannot close because there is a continuous voltage coming across. So that is the reason the muscle will go for paralysis. So that's how, the difference between acetylcholine producing depolarization and activation of the muscle, and succinylcholine producing depolarization and sustained depolarization and paralysis. Okay, now how do you make out what are the characteristics of succinylcholine produced depolarizing block?
There
What
will
are
be
the-
initial fasciculations.
Okay, fasciculations, one, yes. With non-depolarizers, there won't be any fasciculations. Okay, fine.
And then it is faster in onset.
The single twitch response.
Which response would be
That is what, differences between the depolarizing type of block and non-depolarizing type of block. Effect on single twitch. Single twitch amplitude will come down. Both will decrease the single twitch amplitude, whether it is a depolarizing block or a non-depolarizing block. What happens to train of 4 with succinylcholine?
no fading.
There is no fading.
No
So
fading.
all 4 responses will be decreased, isn't it? There is no fading. So train of 4 ratio remains same because there is no fading. So the amplitude of the first response and the amplitude of the fourth response will remain same. So the ratio between the fourth response to first response will remain same. So the train of 4 ratio will not change. It remains as 1. Okay. What about the tetanic stimulation? With succinylcholine.
Would be sus.
Again, only the amplitude will decrease, but no fading.
No fading.
No fading, unlike non-depolarizers. And there is no post-tetanic potentiation.
No post-tetanic potentiation.
No post-tetanic potentiation. Isn't it? So these are the characteristics of by using a neuromuscular junction monitor. What about when you use and anticholinergics with succinylcholine. Suppose I also give neostigmine.
Phase 2 blockade. Phase 2
Can potentiate the effects of
Effects of
succinylcholine, isn't it? So whereas the non-depolarizing block will get reversed. So these are some of the characteristics of depolarizing block. Invariably, you will be asked in the exam when you are given a vial of succinylcholine, what are the characteristics you see at the neuromuscular junction, and also characteristics of succinylcholine block. So most important thing is because it's a depolarizing muscle relaxant, it produces fasciculations and absolutely no fade as far as kinetochore or tetanic response is concerned, and also no question of post-tetanic potentiation with succinylcholine. And anticholinergics will actually produce a more prolonged blockade of succinylcholine block. Okay, so these are some of the differences between the the characteristic of succinylcholine. So now, how actually the metabolism of succinylcholine occurs? We said that it is metabolized by pseudocholinesterase. How many steps of metabolism occurs and why it is important for us to know about?
Sir, this hydrolyzed by plasma cholinesterase into succinic acid and choline, sir.
The plasma succinylcholine is converted to what? Is it
Succinic acid and
not succinic acid directly? It is actually monosuccinylcholine and then choline. First reaction by pseudocholinesterase is, it gets converted to monosuccinylcholine and monosuccinylcholine is again converted to succinic acid and choline. And the first reaction of succinylcholine to monosuccinylcholine is a very rapid one, very fast one. And monosuccinylcholine getting converted to, succinic acid and choline is a slow process. It takes a long time. So why again this is very important for us to know? Why this, fast reaction or fast conversion of succinylcholine to succinyl monocholine? It is succinyl monocholine and choline. And then succinyl monocholine to succinic acid and choline. Why this is important? Succinyl monocholine.
Thus it corresponds with the faster diffusibility, since it has lower lipid solubility, faster diffusibility in the blood.
There is no question of lipid solubility because these are quaternary ammonium compounds that are all hydrophilic compounds. There is no question of initially only we discuss all non-depolarized, all neuromuscular blocking agents are water soluble. They are quaternary ammonium compounds that do not cross the blood-brain barrier. They are not lipophilic. They are all hydrophilic. So that is what already we discussed. Now, why this is important is when you give repeat dose of succinylcholine, is there any complication that can it produce or a side effect it can produce?
Yes, sir. It can actually, there will be a phase 1, phase 2 block.
Phase 2 block is entirely different. Multiple repeated doses are given. Any effect on the heart when you give,
will reduce the.
No, when you give a second dose of succinylcholine, you have to be careful about. Many times, you may have to give a second dose. For example, you have got difficulty in intubation. So sometimes you give a second dose of succinylcholine, or for a short procedure, which you can manage with 2-3 repeated doses of succinylcholine, you can always give a repeat dose.
hyperkalemia, sir.
Second dose of succinylcholine, you should be careful because it can produce bradycardia. That is why if you want to use a second dose of succinylcholine, sometimes you may have to first give atropine and then give second dose of succinylcholine. And what is the cause for this bradycardia? Because we were just discussing about succinyl monocholine, the fast reaction and then the slow reaction. Because, once you give succinylcholine, I told you it, degrades to succinyl monocholine very fast, isn't it? And again, succinyl monocholine to get converted to succinic acid and choline, it takes a long time. But when you give a repeat dose, this again, repeat dose also gets converted to succinyl monocholine because it's a fast reaction. There is a sudden accumulation of succinyl monocholine and the effect of succinyl monocholine on the SA node. Because, muscarinic receptors in the SA node is bradycardia. So there can be an intense bradycardia that can occur with a second dose of succinylcholine. This is again very commonly asked exam question. So why you should be very careful about when you are giving second dose of succinylcholine, repeat dose of succinylcholine, because it can produce bradycardia. Bradycardia is mainly because of the accumulation of succinyl monocholine and sudden increased succinyl monocholine levels can produce inhibitory effect on the SA node and can produce bradycardia, and even junctional bradycardia is very common because SA node is suppressed. Now AV node will take over, and that's how many times there can be junctional bradycardia. And initially you also said about phase 2 block. So what is this phase 2 block? What is phase 1 block? What is and phase 2 block? Already we discussed what is phase 1 block with succinylcholine, isn't it? All the characteristics we said, no fading with rhinophore, no fading with tetanic stimulus. So now you just, said about phase 2 block, because in the exam, you have to be extremely careful. What you say, that will be, that will lead to further questions on that particular thing. Now, because you said phase 2 block, very important. Again, phase 2 block is important with succinylcholine. So what is phase 2 block? How do you define phase 2 block? And phase 2 block can be a 10-mark short notes for you.
Sir, prolonged end-plate depolarization is...
Now, what is phase 2 block? Define phase 2 block.
Long exposure to pseudocholinesterase.
Now, what is phase 2 block? First, you have to define phase 2 block, isn't it? No, if, it is the characteristics of a non-depolarizing block produced by a depolarizing agent is called as phase 2. Non-depolarizing type of block produced by a depolarizer is called as phase 2 block. Now you understood. That means when phase 2 block occurs, there is going to be a trinophore fading will be there. And, trinophore ratio will alter. And there will be a fading with tetanic stimulus. And there is presence of post-tetanic potentiation also. And post-tetanic count also will be there. So these are characteristics of a non-depolarizing block. And these characteristics of a non-depolarizing block produced by a depolarizing agent is called as phase 2. Now you understood. So when phase 2 block can occur?
So,
Normally, there won't be any phase 2 block, isn't it? When you give a single dose of succinylcholine, you intubate, everything is fine. There won't be any phase 2 block. It is typical phase 1 or depolarizing type of block. Now, when phase 2 block occurs actually?
Give repeated doses.
Now, okay, one is repeated doses and total dose exceeding how much? When
More
you
than
give
3 mg per kg.
Very good. So more than 3 milligrams or 10 times the ED95
ED95
of succinylcholine. ED95 of succinylcholine is 0.3 milligrams
0.3
per kg body weight. So when it exceeds 10 times, you can have phase 2 block. One. Then in our time, we used to give succinylcholine as an infusion many times because we had only either succinylcholine or long-acting non-depolarizers like galamine triethiodide or panchronium or DTC. So especially, patients with abdominal emergencies, especially perforated bowel, they used to have a lot of acid-base imbalances and the electrolyte imbalances. So whenever we used to give non-depolarizing drugs, they never used to come out of non-depolarizing agents blocking because there used to be a prolonged block because we had only long-acting non-depolarizers. I still remember in Ballari, one of our friends had given non-depolarizing muscle relaxant. He intubated the patient with perforated bowel, duodenal perforation with succinylcholine. There was no problem. Then he gave pancuronium, and the surgery was over after 1.5 hours. The patient was not coming out. So he continued to ventilate because, during those days, no mechanical ventilators. He had only, either Boyle's F, and you had to only keep manually ventilating. So he ventilated, it started around 3 o'clock in the afternoon. Up to 9 o'clock, he ventilated. And he sent the ambulance for me. There was no mobiles also, no question of contacting. So he sent an ambulance for me to replace him. There were no postgraduates also. So I went and replaced. Whole night I ventilated the patient. So in the early morning, around 5 o'clock or 6 o'clock, there was some movement of the patient. By 9 o'clock, the patient completely came out of the phase 2, with non-depolarizing muscle relaxant block because such a prolonged duration of non-depolarizers used to occur. So that's the reason why many times we did not have ecuronium, we did not have rocuronium, no atracurium, cisatracurium, nothing. We had to use either a long-acting non-depolarizer or succinylcholine. So that's how, many times we used to use succinylcholine infusion also. So whenever they require relaxation, you run the infusion fast. Otherwise, you just, very, very slow infusion. That is what we used to manage. We used to be experts in managing succinylcholine. You have not heard about these things, of course. So, but when you use succinylcholine infusion, if you cross 1 gram total infusion, that also could produce phase 2 block. That's how, phase 2 block is important for us to know again, because it is important for you to know, is because one is theory, short notes is usually given. Second thing is whenever you are asked about succinylcholine, invariably they'll be asking you about phase 2 block. A non-depolarizing type of block produced by succinylcholine is called as phase 2 block. Now, what is the mechanism of phase 2 block? Why phase 2 block can act? Why a non-depolarizing type of block? Why the fading? Normally, why succinylcholine does not produce fading? Because we said that fading is pre-junctional, isn't it? Presynaptic, where alpha 3 and beta 2 receptors, they are in the pre-junctional or presynaptic nerve ending. If they get blocked, so there won't be any mobility of reserve acetylcholine towards the immediately available acetylcholine. That is what the next stimulus, there is not much of an acetylcholine available for release. That produces a decrease in the amplitude, and that is called as fading. Normally, because non-depolarizers act on alpha 3 beta 2 receptors in the presynaptic nerve ending and block them, that's how, mobility of the reserve acetylcholine towards the immediately available acetylcholine does not occur. That is how fading occurs. Succinylcholine with normal doses does not have any effect on alpha 3 beta 2 receptors. That is the reason why you don't have fading with succinylcholine. Now with phase 2 block, there is fading. Why there is fading with phase 2 block? No, it is given in Barash. People said that you read Barash. It is given in every book. So it requires to read every line when you are reading and to know its importance. Now that is the importance of, discussion. Once we discuss, again, when you go and read, you don't forget things because you know exactly why that particular line, what is written there in the textbook is important, isn't it? So that's how, these discussions are very, very important. In higher doses, succinylcholine also blocks alpha-3 beta-2 receptors. In regular doses of 1 to 1.5 milligram per kg body weight, succinylcholine has got no effect on alpha-3 beta-2 receptors in the presynaptic nerve ending, the nicotinic receptors there. But when you give 3 milligram per kg body weight or higher than that, so that is going to produce blockade of alpha-3 beta-2 receptors. Once these receptors are blocked, now, there is no shifting of the reserve acetylcholine towards the immediately available acetylcholine area. So that's how next stimulus, there will be a decrease in the response. And that is what fading is. So that is the explanation given for the non-depolarizing type of block produced by succinylcholine. But what is the basic mechanism of prolonged block? Whenever phase 2 block occurs, there can be a prolonged duration of block. That you should always remember about. There can be prolonged blockade can occur or prolonged paralysis can occur because normally, what is the duration of action of succinylcholine?
10 to 20 minutes up to 20 to 30 minutes maximum.
Normal succinylcholine duration of action.
7 to 12.
10 minutes.
Just, 5 to 7 minutes maximum. That is what, when you are doing an intubation with succinylcholine, after about 5 minutes or 7 minutes, already patient is moving and you give a non-depolarizer. Isn't it? Routinely
Yes.
you are doing. So that means the duration of action must be around 7 minutes,
10
maximum
minutes.
about 10 minutes. Isn't it? Usually it will not prolong. Isn't it? So, but with phase 2 block, it can get really prolonged because you are given so much of high dose, or when you are given an infusion, you are given more than 1 gram of infusion. So why this prolonged paralysis occurs? With phase 2.
So dogs are for
Pardon?
One, it blocks the receptors, and two, there is no reserve vesicles to.
No, that is why fading occurs. That is what I told you. It is fading. Now, why succinylcholine produces, the prolonged paralysis or the phase 2 block, what we call it as. Now, one thing you should realize that whenever succinylcholine is given, a certain number of receptors in the motor end plate, the nicotinic receptors, regular alpha-2, beta-1, then delta-1 and then epsilon-1 receptors, there will be a conformational change. And they'll not be, again, can be, acted upon by acetylcholine, normally also. Small number of receptors, and that we call it as desensitization of receptors. We call it as desensitization.
Desensitization.
They'll not be sensitive to acetylcholine effect again. A small group of nicotinic receptors, so that will not matter much. So once succinylcholine effect goes off, the patients will the neuromuscular junction will be effective for acetylcholine normally, because only a small number of receptors have gone into a desensitization state. But when you keep giving repeated doses of succinylcholine, and when you exceed more than 3 milligram per kg body weight of succinylcholine, large number of acetylcholine receptors at the neuromuscular junction, that is at the motor end plate, goes into desensitization state. That means they cannot be acted upon by acetylcholine. Did you understand? When you give a single dose, only a small group of receptors will go for conformational change, and that is, they'll not be sensitive to acetylcholine, and we call that state as the desensitization state. So when you keep giving regularly repeat doses, and you exceed a very high dose of succinylcholine, large number of acetylcholine receptors at the motor end plate will go into a state called as desensitization state. So that means they'll not be responsive for acetylcholine. That's how, there can be a prolongation of the duration of action of acetylcholine. Again, these conformational changes has to come back to its original state. It takes a long time. Again, these receptors to be sensitive to acetylcholine, it takes a long time. And that is what we call it as the phase 2 block that is produced by repeat doses of succinylcholine. And because it also acts on the alpha-3 beta-2 receptors in the presynaptic area, we get the fading. Okay. Now, how do you treat? Suppose by mistake you have given high dose or repeated dose and the patient has gone for phase 2 block. You are also monitoring the patient with neuromuscular junction monitoring. Suddenly you are seeing fading with trainer 4 and use a tetanic response. Again, there is a fading. Now, patient has gone from depolarization to non-depolarization type of block, that is phase 2 block. So how do you manage? Can you reverse this by giving neostigmine? Because we know non-depolarization type of block will be reversed by neostigmine. Can you reverse it?
No.
No, sir.
So actually, sometimes if it is purely non-depolarizing type of block or phase 2 block, there will be a reversal. If it is a purely, non-depolarizing type of block. But what happens is that actually these receptors will be in the 3 states of block. One is they can be in the depolarization state of block. There can be a transitional phase of the change in the conformational change that is occurring. And third is there will be a non-depolarizing type of block. So these will be 3 states. So a depolarizing state, a transitional phase, and totally phase 2 phase. So when you give neostigmine, so the depolarization type of block can get intensified and again phase 2 block can occur. Because neostigmine will increase the acetylcholine levels. Or a transitional phase can go into phase 2, typical phase 2. So that is why if only the phase 2 can get reversed, but again phase 1 and transitional phase can go into phase 2. So that is the reason why there is no point in giving neostigmine as a reversal for phase 2 block of succinylcholine. You don't give. But how do you manage?
We just actually wait till the.
We will just wait on this.
We actually wait.
No, you continue to
We have
ventilate
continue to ventilate and wait.
till the patient comes out. And you keep checking for the neuromuscular junction monitoring. And once there is no fade and trainer 4 is more than 0.1 or 1, patient is completely come out of neuromuscular blocking in the phase 2 block. So definitely you can extubate the patient. So till then you sedate the patient and ventilate the patient. So that's how you manage phase 2 block. Again, phase 2 block, very important. Now you know what is the theory behind phase 2 block and why there is a non-depolarizing type of block. What is the effect of succinylcholine on alpha-3 beta-2 receptors in the prejunctional area? So these are all very important to know about. Okay, now coming to the normal duration of action of succinylcholine, you said is about 5 to 8 minutes, isn't it? So because it is acted upon by plasma cholinesterase and immediately it gets metabolized. So when you give succinylcholine intravenously, because the dose of succinylcholine is 1 to 1.5 milligram per kg body weight. And once you give this, how do you give? succinylcholine? You give very slowly or give rapidly?
We give rapidly.
Rapidly, sir.
Why should you give rapidly succinylcholine? What happens if you give very slowly? Like majority of the drugs, anesthesia drugs, we always give slowly, isn't it? Whether it is thiopentone, propofol, lidocaine, whatever it may be.
Sir,
What happens if you give slowly succinylcholine?
sir, it has rapid metabolism into succinyl
Correct.
monomer, sir.
So rapidly it gets metabolized in the plasma by pseudocholinesterase. So
So giving slowly has no use.
what happens when you
Give
give
it-
slowly?
When you give slowly, there is more diffusion of the drug into the peripheral circulation, so that the amount of drug that goes for the muscle, I mean
Not
the
distribution, it is metabolized, isn't it? It is
yes,
rapidly metabolized in the plasma.
rapid,
And hardly any succinylcholine molecules can reach the neuromuscular junction to produce
junction.
sustained depolarization and paralysis. So there won't be any effect when you give slowly. So that is the reason why you have to give very fast succinylcholine, very rapidly. And when you give rapidly also, what is the amount of succinylcholine that reaches the neuromuscular junction? Percentage of,
Less than 10% of the drug.
it is just 10%. That means 90% of succinylcholine, even though you have given is very rapidly or very fast, 90% of it is already metabolized in the by the pseudocholinesterase in the plasma. Hardly 10% will reach, and this 10% is enough to produce paralysis and depolarization type of block. That is why this is again another exam question, why you should not give slowly succinylcholine. So, and the duration of action of 1 to 1.5 milligram per kg body weight is 5 to 8 minutes. Something called as choline apnea is there. What is this choline apnea? Again, another short notes commonly asked, and another exam question in the practicals invariably will be asked. What is this choline apnea and what are the causes of choline apnea? And defines choline apnea. What
It
is choline
happens
apnea?
when
No,
it
what is
happen
choline
when
apnea? No, when you are asked a
Can,
particular question, first you should answer that question. Like, what is choline apnea? Define. Definition of.
the effect of succinylcholine is prolonged.
No, when you say prolonged means how long? You say choline apnea.
The usually patient comes out in 10 minutes, but in apnea, the effect is there at least minimum for 30 to 45 minutes.
No, what is choline apnea? Definition of choline apnea is when the duration of paralysis with succinylcholine prolongs for more than 20 minutes. When apnea gets prolonged, apnea means what? The patient is paralyzed.
Paralyzed.
He is not able to breathe. Normally also choline produces apnea, isn't it? Paralyzes the diaphragm. So once the diaphragm is paralyzed, the patient is apneic. But we don't call that as choline apnea. When we call it as choline apnea is when this apnea gets prolonged or when this paralysis gets prolonged for more than 20 minutes. So that is very important for defining. When the duration of action of succinylcholine is prolonged for more than 20 minutes, you call it as choline apnea. Now, what are the causes of choline apnea? It is not phase 2 block.
No.
Phase 2 block is
It
different.
it is either because of reduced.
What is the difference between phase 2 block and choline apnea?
Sir, in patients with pseudocholinesterase deficiency, sir.
No, choline apnea is with a normal dose. Prolongation of the paralysis for more than 20 minutes with a normal dose is called as choline apnea. Whereas with high dose, you call it as phase 2 block. Now you know the difference between choline
Yes.
apnea and phase 2 block. And what is the cause for choline apnea?
Reduced level of pseudocholinesterase or aberrant homozygous pseudocholinesterase.
Atypical pseudocholinesterase.
Atypical pseudocholinesterase.
There are two things. One is there is actually because there is a deficiency of pseudocholinesterase. And this deficiency can be quantitative or qualitative. That is what you have to write down also. And when you are talking also, when you're telling, you have to tell about. Because choline apnea is basically because of the deficiency of pseudocholinesterase. And this deficiency can be quantitative. That means the quantity of pseudocholinesterase has come down. That is what is producing a prolongation of the effect of succinylcholine. Second thing is qualitative. The pseudocholinesterase quantity is enough, but the quality is poor. It is not able to metabolize succinylcholine. That is why there is a prolongation of the effect of succinylcholine. Now you know the difference between quantitative deficiency and qualitative deficiency. Now, what are the factors which influence the quantity of pseudocholinesterase? What are the factors which decrease the pseudocholinesterase level? Quantitatively. What are the physiological factors which can decrease the pseudocholinesterase level? Physiological factors which can decrease the pseudocholinesterase level. Already we have discussed this before. Dilutional effect, because in particular state of physiology. Where there will be increase in the plasma level and the total blood volume by 50%. In which condition? RBC level will increase by 20%. Plasma level will increase by 50%, 40%. Total blood volume will increase by 50%, which is going to dilute everything that is there in the blood.
Pregnancy.
Simple thing. I'm giving you so many clues to catch up, isn't it? Pregnancy, because there is, pseudocholinesterase is synthesized from the liver. That you should always realize. In pregnancy, the amount of pseudocholinesterase synthesis does not alter. It is only because the plasma volume will increase so much, the blood volume will increase so much. There is a dilutional effect on the pseudocholinesterase levels also. That is how there can be a decrease in the quantity of pseudocholinesterase in the blood. That is one thing. What are the other physiological? Again, in puerperium. Because after 6 weeks, all these physiological changes can continue. And again, there can be, so in both pregnancy and immediately after the delivery of the fetus for at least about 6 weeks, there can be slight prolongation of the duration of action of succinylcholine, but not to the extent of producing choline apnea. Maybe say, instead of 5 to 7 minutes, the patient is coming out, she may take about 10 to 15 minutes maximum. But you should know about this. In pregnancy, there will be slight increase in the duration of action of succinylcholine because of quantitative decrease in the levels of pseudocholinesterase, again in puerperium. Again, if the patients are taking certain drugs, especially the oral contraceptives, again, there can be a decrease in the quantity of pseudocholinesterase level in the blood. So that is another. So these are just physiological things. Okay, what are the pathological conditions which can produce a decrease in the plasma cholinesterase level? Pathological condition. Where pseudocholinesterase synthesis can be altered or synthesis can be decreased. I told you it is synthesized from the liver.
Cirrhosis.
Yeah, liver disorders.
Liver disorders.
It is very easy.
Alcoholic liver disorders.
Whatever it may be, any liver disease, the synthesis of pseudocholinesterase can decrease, and that can produce a quantitative deficiency of pseudocholinesterase. Okay, what are the other factors which influence this synthesis? Which are all the conditions where it requires protein ingestion for production of pseudocholinesterase, just like albumin. In which condition synthesis can be decreased? where protein intake can be reduced? Or what are the conditions where the patients are not taking enough of food? What do you call that condition? Nutritionally deficiency. What?
Bulimia,
Malnutrition.
malnutrition.
In malnutrition patients, they're not taking enough of protein. So again, synthesis of pseudocholesterol is decreased. Again, in what all the patients wherein there can be a problem in the production of pseudocholesterol, where a lot of nutrition is used up by other cells other than the regular cells.
The diabetes.
Malignancies.
Malignancies, cancers.
Isn't it? All malignancies, the pseudocholesterol levels can be reduced. You have to be careful. There can be prolongation of duration of action of succinylcholine. And patients on radiotherapy. If the patients on radiotherapy, again, there can be decrease in the pseudocholesterol levels. Then advanced age, geriatric patients, pseudocholesterol levels can be decreased, and patients with massive burns. So all these are, can produce a decrease in the production of pseudocholesterol synthesis. And there are certain drugs which can, compete with for pseudocholesterol with succinylcholine. They can reduce the levels of pseudocholesterol because they are also getting metabolized by pseudocholesterol. So that when the patients are on these drugs, there can be a decrease in the level of pseudocholesterol, and succinylcholine will have a prolonged duration effect. So what are the drugs which can compete with succinylcholine for pseudocholesterol? Can you just give some examples? I'll give you a clue. Local anesthetics. Which local anesthetics are metabolized by pseudocholesterol? Lidocaine is metabolized in the liver. It is not metabolized by pseudocholesterol. Already we have had an extensive discussion on local anesthetics, just previous classes. Which local anesthetics are metabolized by pseudocholesterol or plasma cholesterol? All ester group of local anesthetics except cocaine. Your procaine, chloroprocaine, and your amitocaine, all these are metabolized by pseudocholesterol. So if you are giving procaine, cocaine, or procaine and chloroprocaine and amitocaine or tetracaine, along with the patient is also being given succinylcholine, there can be prolongation of the effect of succinylcholine. So local anesthetics. Okay, how about IV anesthetic agent? Which IV anesthetic agents can prolong the duration? Because they are also metabolized by pseudocholesterol. With the IV anesthetic agent which we are not using. I'll tell you because let us not waste time. Propanidine. Propanidine was one of the IV anesthetic agents which was metabolized by pseudocholesterol. It could prolong the duration of action of succinylcholine. So which antiarrhythmic drugs can have an effect on succinylcholine duration?
Quinidine, calcium channel blockers.
Not quinidine, it is procainamide. Procainamide and esmolol may require pseudocholesterol and they may prolong the duration of action of succinylcholine. So what about antihypertensives? Any antihypertensive which can produce prolongation? Choline apnea is commonly asked short notes and also commonly asked. All these things you will have to write down when choline apnea is asked. What drugs can, what antiarrhythmic drugs? One I told you, esmolol already I have told you. Antihypertensive. What antihypertensives? Now, which we are not using actually, ganglion blockers, hexamethonium. one of the ganglion blockers, because it requires pseudocholesterol for its metabolism, it can prolong. It can compete with succinyl. Okay, any anti-glaucoma drug can produce prolonged duration of action of succinylcholine. Anti-glaucoma agent. Ecothiophyte. Ecothiophyte is one of the anti-glaucoma agent. It is an organophosphorus agent. So it again, blocks pseudocholesterol and it prolongs the duration of action of, succinylcholine. And again, if the patient is on drugs like anticholinesterases, already we have discussed, like for example, patient on neostigmine, like myasthenia gravis patient, pyridostigmine, neostigmine, again, blocking of pseudocholinesterase also will be there. And patients with organophosphorus compound poisoning. Suppose, there are incidences wherein a patient who has consumed organophosphorus compound and has brought for surgery. We had one case wherein patient had he wanted to commit suicide. What he does was he had taken organophosphorus compound and also he had stabbed himself in the abdomen. So naturally now he has to be taken up for an emergency surgery. Now, once the patient has taken organophosphorus compound, now we know that it is going to block both acetylcholinesterase and pseudocholinesterase. There will be large amount of release of acetylcholine in the neuromuscular junction. And that is the one which has already produced a phase 2 type of block. Isn't it? And it is also blocking pseudocholinesterase. Now, for rapid sequence induction, you usually, because it's an emergency, you always go for a rapid sequence induction. So you have to give either succinylcholine, and if you give succinylcholine, you don't know how long it's going to act, because already blocking of the pseudocholinesterase in the plasma is there by OP, organophosphorus compound. It is produce an irreversible blockade of both acetylcholinesterase and pseudocholinesterase. And if you want to give non-depolarizer, because there is so much of acetylcholine at the neuromuscular junction, there can be resistance also for the action of non-depolarizer. Isn't it? So in such situation, how are you going to manage? How do you intubate the patient? No, it is a real problem, isn't it? You have to go for a rapid sequence induction. And you don't know, if you give succinylcholine, the patient may not come out immediately. It may take many hours. And if you give non-depolarizer, there may be resistance. This was a common question that used to be asked many times back when we used to have 20 marks question. Now we don't have such essay type of question. Or you may be asked a question like, patient on OP poisoning, posted for emergency laparotomy, how are you going to manage? So this you have to discuss in such situation. Because you must have seen in these patients with OP poisoning, they'll have fasciculations, muscle fasciculation. And that muscle fasciculation is because of the depolarization produced by large amount of acetylcholine that is present in the neuromuscular junction, because of the blocking of acetylcholinesterase by the OP, organophosphorus compound. That sustained depolarization produces phase 2 block also with OP. So if these patients come, so there will be a real dilemma for us how to manage, whether to give succinylcholine for intubation or whether to go for rocuronium for intubation. So it is always better not to use succinylcholine. It is better to go for rocuronium. You can definitely go for 1.2 milligram per kg body weight of rocuronium. And then, you can get good intubating conditions and you can intubate, but this dilemma is always there. There may be resistance for non-depolarizers and highly sensitive neuromuscular junction for depolarizers. So that is another, thing which can produce decrease in the pseudocholesterol level. So these are all the factors which can decrease quantitative deficiency, or can produce quantitative deficiency of pseudocholesterol. Coming to qualitative deficiency of pseudocholesterol, you are telling about atypical pseudocholesterol. How do you classify this atypical pseudocholesterol? How many types of atypical pseudocholesterol are there? All these are there in your regular textbooks. Miller, Barash. How many types of atypical pseudocholesterol is there? It is a genetically transmitted problem. Atypical pseudocholesterol. It comes through the genes. That's why you must have heard about, when you are asking about when you are doing a pre-anesthetic evaluation, many times we are asking about, are you a Vaishya from Vaishya community? I don't know whether in Pondicherry also you'll be asking about this or not. At least in Karnataka, we do ask. And in Ballari, when I was there, it used to be rampant. So many of these Vaishya people, they used to carry this atypical pseudocholesterol gene. And we used to avoid using succinylcholine for these patients because the genetic inheritance was there, and it used to take a long time for them to come out of succinylcholine if we happen to give them, because invariably they used to go for choline apnea. So what are the different types of these atypical pseudocholesterol? The three types of atypical pseudocholesterol. Can you just name them? Three types I told you.
Butyryl cholinesterase.
Butyryl pseudocholesterase is same as plasma cholesterase, same as pseudocholesterase. Different names, that's all. Different names for the same enzyme. What are the three types of atypical pseudocholesterase? Anyway, there is one type is called as Debukane resistant pseudocholesterase, which is more common. Debukane resistant. Second thing is a fluoride resistant pseudocholesterase. Third is a silent variety of pseudocholesterase. Silent variety. So again, Debukane is an amide local anesthetic. So usually this Debukane is going to inhibit the pseudocholesterase. Normally we check how much of the pseudocholesterase, percentage of pseudocholesterase is inhibited by Debukane. And that is called as a Debukane number. Debukane number is defined as the percentage inhibition of molar concentration of pseudocholesterase. Percentage inhibition of molar concentration of pseudocholesterase by Debukane is called as Debukane number. Normally it is 75 to 80.
80.
That means 75 to 80% of pseudocholesterase is inhibited normally by Debukane. This is normal pseudocholesterase. If the Debukane number is 75 to 80, you call it as a normal pseudocholesterase. It is a typical pseudocholesterase. It is not atypical pseudocholesterase. Atypical pseudocholesterase is Debukane resistant. Debukane will not be able to inhibit this atypical pseudocholesterase. Again, there are two varieties here. I think you are telling, Siddharth, about homozygous and heterozygous.
Homozygous and heterozygous.
Because if both the genes in the chromosome are carrying atypical type of genes, it is called as homozygous variety. If only one gene is carrying the atypical variety and the other gene is normal, it is called as heterozygous type. In heterozygous type of pseudocholesterase, where one gene is involved, other gene is not involved, Debukane number is usually around 60.
50 to 60.
Yeah, it is reduced, but it is around 60. There won't be choline apnea. Not much of prolongation. Slight prolongation, maybe about half an hour, 1 hour or so, maximum 2 hours. Whereas when you have both the genes, homozygous variety of atypical pseudocholesterase, then it can be prolonged duration. It can be 7 hours, 8 hours or so. That is, usually it is represented normal, typical pseudocholesterase is represented as, E1U, E1U. That is a normal pseudocholesterase. E capital, 1 U. U is usual. That is a typical pseudo. Even U, even U. In heterozygous, you have even U, even A, atypical pseudokinase. Even U, even A is heterozygous. If it is even A, even A, it is a homozygous variety where there can be a prolonged duration of action of pseudocholinesterase. I told you another variety is there which is called as fluoride resistant. Normally, fluoride also can inhibit pseudocholinesterase. Whereas this type of pseudocholinesterase, where dipukane is normally inhibiting, dipukane number is 60 to 80 or 75 to 80, but fluoride resistance is there. This is again an atypical pseudocholinesterase, where there can be prolongation of the duration of action of succinylcholine, but this number is very less. The percentage of people carrying fluoride resistant atypical pseudocholinesterase is very less. There's a third variety is there, which is called as silent variety, wherein it is called as even S, even S. That is the homozygous variety, or even U, even S. It is silent variety, heterozygous type. Again, you have homozygous and heterozygous silent variety. And in even S, silent variety, there is zero effectiveness of pseudocholinesterase. That means when you give succinylcholine, it cannot be metabolized by succinylcholine because the quantity will be normal, the quality is zero in homozygous silent variety, where there can be a prolonged duration of action of succinylcholine. It can be even maybe more than 24 hours, even 48 hours. That is silent variety, which is the most dangerous of all the atypical pseudocholinesterase. That's why you should know about dipukane resistant to atypical pseudocholinesterase, fluoride resistant atypical pseudocholinesterase, silent variety of pseudocholinesterase, how it is represented, even U, even S, or even U, even A, even A, even A. So these are all the atypical pseudocholinesterases. So if you have a atypical pseudocholinesterase, there can be the duration of action of succinylcholine can get really prolonged. It can be more than, I told you, sometimes 8 hours, 10 hours. So I still remember, when I was in Ballari, invariably we used to ask the patients whether they belong to Vaishya community, and if the patient belonged to Vaishya community, we never used to give succinylcholine for those patients. Actually, for Professor in 1970s, they had done a study on these patients, the Vaishya people. They had collected all the blood of these Vaishya patients and estimated how many of them have atypical pseudocholinesterase, and many of them had atypical pseudocholinesterase. That is the reason we never used to administer atypical succinylcholine for these patients with who are Vaishya community, belong to Vaishya community. Vaishya community is a merchant community, especially in Karnataka and especially in Ballari. So everywhere we usually ask about this. I still remember there was one child, which was the child's age was about 2 days, and the child had intestinal obstruction. This is because of ileal atresia, and the child was brought for laparotomy. I, saw the case sheet. The patient's child's father's name was Robert or something like that. So invariably, when it is Robert, you don't ask the, which caste
Community do you belong?
Community patient belongs to, in Christian community. So it's an emergency. So you have to go for rapid sequence induction, even though it is a 2-day-old child. I gave succinylcholine, intubated the child, everything was fine. The child was not coming out of succinylcholine. It was, half an hour. I thought neonate, especially neonates, also may have decreased amount of pseudocholinesterase. I thought maybe because of that. But it was half an hour, it was 45 minutes, no response. And then, I went out and then asked the, father. Mother was from Vaishak. Now you understood, the problem. Father was from Christian community, mother was from Vaishya community. So there was a transmission of this atypical pseudochondrosis gene to the child. So who will ask mother also, if father is a Christian, and so that's how, So I had to ventilate the child for a long time, for almost, the surgery was over after about 1.5 hours. So the child came out in the night. So there were no ventilators during those days. With Jacksonville's modification of ISTP's type of, circuit, I was ventilating. I was all alone. So I still remember that particular incident. Another incident was for an old man, say 70-year-old man, who had come for urethral dilatation for stricture urethra. So the method of my management for such patients was, I used to give thiopental and a regular dose of succinylcholine, and 5 to 8 minutes, the surgery used to be over. Endoscopic stricturotomy used to be over, and the patients will come out of succinylcholine, and I used to send outpatient procedures. So this patient came, unfortunately, I was so busy with the previous surgeries, I did not ask his, community. He was actually belonged to Vaishya community. I gave succinylcholine, he was not coming. Then afterwards, I went out and asked, he was actually from Vaishya community. Now what to do? I continued to ventilate. And during those days, there was no air for us to ventilate, oxygen air. Or you had to ventilate with oxygen oxide. And I was ventilating this patient. And this patient came out by about 5 o'clock this occurred around 6 o'clock in the morning. He came out around 5 o'clock in the evening. So everything was all right. I continued to ventilate. And I was all alone inside the OT, and nobody will be there inside the OT. And that is a real, hell of a problem. And nobody will come to your rescue also, because nobody will know how to ventilate. There are hardly any anesthetists in Ballari during those days. We were about 3 or 4. You can't ask for help also. So I continued to ventilate, and occasionally the OT sister used to open the door, peep, sir, what is happening? I used to say, no, nothing. And she used to go out. Surgeon had gone out, and then he finished his outpatient outside. By the time he came back, but the patient came out at 5 o'clock. Everything was fine. But in the night, we saw the distension of abdomen of the patient. And we got an X-ray in the erect posture, and there was air under the diaphragm. Then the surgeon blamed me. Actually, he did not blame me directly. He said, sir, maybe because of the stress, you were ventilating for a long time, the stress, there must have been duodenal perforation. Now to open him again. So because, he had placed a catheter, and through the catheter, urine was coming out. After endostricturotomy, he had placed the catheter, and urine was coming out, and the bladder was filling. There was no problem. The bladder of the catheter leading to this bladder was filling. So anyway, so I did not give succinylcholine for repeat laparotomy. I gave pancuronium during those days, either calamine or pancuronium. I gave pancuronium, intubated the patient. So when laparotomy was done, actually what had happened was he had perforated the bladder, the urologist, and the Foley's catheter had gone through the perforation, and it was in the peritoneal cavity. Urine was draining into the peritoneal cavity, and it was coming out through the, the catheter. And that's how, we were thinking that everything is fine. But then he came to know that it was his fault that the patient required a repeat surgery. So he was really apologetic afterwards. So there used to be cases like this, scoline apnea used to be common during those days. And you had to inquire because there were no alternative for such. So That is the problem with atypical pseudocolon stress and choline apnea. So if there is choline apnea, how do you manage choline apnea?
Just continue to ventilate till the patient comes out. We have no other.
Can we give blood transfusion or during those days it was said that plasma? Can we give fresh frozen plasma for these patients? Because fresh frozen plasma also contains pseudocolon stress of others, not these relatives. Can it be given so that the patient can come out, because you are giving
Sir,
pseudocolon?
as you said, if they belong to the same community, they might have.
No. You have fresh frozen plasma in the blood bank.
If it
That's
is
why I
from,
told not from the same community fresh frozen plasma.
if it is from others, we can try.
No, there is no point in giving, because the amount of fresh frozen plasma required is quite high. You are going to produce circulatory overload for this patient who does not require any fresh frozen plasma. No point in giving fresh frozen plasma. But is it synthetic pseudocholesterol is available? Synthetic pseudocholesterol.
Available.
Pardon? In US, it is available as Coles. So if it is there, but it is very costly, since it is not available in India, there is no point in going in for giving synthetic pseudocholesterol at Coles also. So you continue to ventilate till the patient comes out. So that is what you have to do. Okay. So another situation wherein you can have this problem is, you have just, given neostigmine, reverse the patient, surgery is over. And afterwards, you have to, again, the surgeon says that I want to open up the patient again. Or many times this is very common in tonsillectomies. The surgery is over, everything is fine. You send the patient to the ward and say after about half an hour or 45 minutes, the surgeon notices that there is a lot of bleeding, post-tonsillectomy bleeding. Again, the patient has to be taken. So now this will be a situation wherein you have to re-intubate the patient. And again, for re-intubation, what you have to give? Because already pseudocholesterol is acted upon by neostigmine. Because neostigmine blocks both acetylcholinesterase and pseudocholesterol. Now, if you give succinylcholine, there can be a prolonged duration of action of succinylcholine. It is same situation like OP poisoning, but OP poisoning produces prolonged duration of action. But neostigmine is only for duration of action of neostigmine is about 90 minutes. Within this 90 minutes, if you have to give again succinylcholine, there can be prolonged duration of action of succinylcholine.
We can try with suboptimal doses.
No, but it may not act. How do you know it will act? Or there is always a possibility of, because you have to get excellent intubating conditions for you to intubate, isn't it? Rapid sequence induction. So that is why, so you can even go for rocuronium, but only problem with rocuronium is the duration of action can get really prolonged when you give 1.2 milligram per kg body weight of rocuronium for intubating these children for post-tonsillectomy bleeding, because the duration of surgery may be short, isn't it? It may not take long time. So, but since we have Sugammadex, you can still give rocuronium, intubate, reverse the patient with Sugammadex. That is always there. So these are some of the questions that will be commonly asked for you when you have succinylcholine given to you in the practicals or in theory also, it can be asked. Post-tonsillectomy bleeding, because you have to write down now how do you intubate a patient with post-tonsillectomy bleeding, because again, it is a rapid sequence induction because the child would have swallowed a lot of blood and this blood would have clotted inside the stomach. And there could be aspiration of this blood, and then that can enter into the lungs and can produce aspiration problems. So that is why you have to go for a rapid sequence induction for these children. And the best drug for rapid sequence induction is succinylcholine. But the patient has been reversed with neostigmine. So that can produce, again, a prolonged duration of action of succinylcholine. Okay, now, what are the side effects of succinyl? What are the problems of succinyl?
One, you can have hyperkalemia-induced cardiac arrest.
Most common is myalgias.
Myalgia, post-operative myalgia.
Yeah, it is very common, post-operative myalgias. And it is very, very common in patients who are posted for ambulatory surgeries. Because, ambulatory surgeries, you don't keep them admitted. You keep them admitted only to your post-anesthesia care unit, and afterwards you send them home. They have come for short procedures many times, isn't it? So if you give succinylcholine, there is always a possibility of post-operative myalgia. So that has to be kept in your mind. And what is the cause for this myalgia?
The fasciculations.
Fasciculations. Why fasciculations can produce myalgia?
Because they are not a sustained or coordinated contractions. They are uncoordinated contractions.
Okay. So what they can produce actually? What damage it can produce? One of the theories that is put forward is, damage to the muscle spindles. So damage to the muscle spindles because of uncoordinated contractions of the muscles produced as a result of fasciculations may be the cause. So usually how this is managed, and it is more common in which kind of patients?
With a lot of muscle mass, people with
Very good. So
going to gym and all.
Muscular individuals.
Muscular individuals.
Young males with muscular individuals, it is more common. So how do you prevent it?
Either you do pre-curization or you do self-taming.
What is pre-curization? Because you mentioned
that is, you give a 1/10 intubating dose of a non-depolarizing drug few minutes before giving Saxa, or the same, or self-taming is giving the same 1/10 intubating dose a few minutes before giving the actual intubating.
Of succinylcholine itself.
Yes.
Isn't it? There are three things now here. One is pre-curization is giving a non-depolarizer before a depolarizer. That is called as defasciculating dose or pre-curization. And second thing is self-taming. That is giving a depolarizer before a depolarizer. And another thing is giving non-depolarizer before non-depolarizer. What do you call that? Three different things. One is giving a non-depolarizer before a depolarizer is called as, pre-curization. And giving a depolarizer before a depolarizer is called as self-taming. And sometimes we also give non-depolarizer before a small dose of, say, 1/10 of the intubating dose of non-depolarizer before giving the full dose of non-depolarizer. What is this called as? We'll discuss this when we discuss, non-depolarizers, but I just want to ask the name for this. It's called as priming.
Priming, okay.
Priming.
Okay.
So these three, words you should always, or nomenclatures you should remember. One is pre-curization. Second thing is self-taming.
Self-taming.
Third thing,
Self-taming.
priming. So pre-curization, or you also call it as defasciculating dose of non-depolarizer. So definitely you can use defasciculating dose of non-depolarizer before a depolarizer. So that can produce, there won't be any fasciculations. One way of preventing fasciculations. What is the second way of preventing fasciculation? You must have seen in some patients that
Reducing
severe,
analgesia.
no, in some patients you see severe fasciculations will be there. In some patients there is hardly any fasciculations. You must have, in your 3 years now or 2.5 years, you must have seen sometimes. Some patients have vigorous fasciculations.
Yes, sir.
Some patients have hardly any fasciculation. Deep plane of anesthesia. So if you maintain deep plane of anesthesia before giving succinylcholine, because you always give, pre-induction drugs like, dexmedetomidine or even your opioids, and then midazolam, and then you give propofol. And afterwards only you give succinylcholine, isn't it? So if you have given them sufficient quantity of that, and you have maintained a very deep plane of anesthesia, you can see hardly fasciculations, not many, very slow, very small amount of fasciculations. And if the fasciculations, number of fasciculations are reduced, definitely myalgia will not occur. And again, in which kind of patients you don't see fasciculations? I'll give you, pregnancy. In which kind of patients, pregnant patients, when you want to give GA for cesarean section, you don't see fasciculations. You have to just time it 1 minute and then you have to do a laryngoscopy and intubate. Already we have discussed this just before when we were discussing about, the mechanism of action of neuromuscular junction, the calcium channels and all, and factors affecting calcium channels. Pregnancy.
Preeclamptic patients.
Yeah, if the patient is on magnesium sulfate,
Magnesium sulfate.
you don't see fasciculations. So prior administration of magnesium can prevent fasciculations. So that way you can prevent fasciculation, and that way you can prevent myalgia. And once myalgia occurs, best drug would be to give either paracetamol or non-steroidal anti-inflammatory drugs will definitely help. Okay. The second is the cardiovascular side effects of succinylcholine. What are the cardiovascular side effects of succinylcholine? Already we have just discussed.
Sinus
Bradycardia, as we discussed
Sinus
earlier.
bradycardia, junctional bradycardia, all kinds of dysrhythmias. It can be sinus bradycardia, it can be junctional bradycardia, it can be even ventricular dysrhythmias, ventricular premature contractions, ventricular tachycardia, ventricular fibrillation. All these things are known, and then case reports are there. And again, this is all because there can be, because of the succinylcholine is 2 molecules of acetylcholine. So succinylcholine, because of like acetylcholine, it also can act on muscarinic receptors, and muscarinic receptors in the heart. So muscarinic receptors are there in the conduction system of the heart also, in the SA node, in the AV node, the bundle of phase, Purkinje system, everywhere it's there. So blocking of these muscarinic receptors can induce all kinds of dysrhythmias, and most common is bradycardia and junctional bradycardia. And especially already I told you, it's succinyl monocholine, which is more problematic than succinylcholine itself. And repeat doses can produce accumulation of succinyl monocholine. And it's more common in pediatric patients. And if you have administered atropine before, usually you don't find this problem. That is why whenever if you have not given atropine, if you want to go for a repeat dose of succinylcholine, better you give atropine and then go for repeat doses of succinylcholine. Okay. What about the effect of succinylcholine on the potassium release?
Will be causes hyperkalemia.
Normally, it releases potassium, is it? Succinylcholine with 1 to 1.5 milligram per kg body weight. Succinylcholine. Does it produce hyperkalemia or it won't produce hyperkalemia?
Sir, increases potassium levels by 0.5 milliequivalents.
Milliequivalents per liter. Normally, because it is a depolarizing block. It produces depolarization at the neuromuscular junction. What is depolarization? Sodium will enter, potassium will come out.
Potassium will come
So
out.
potassium will enter the extracellular compartment. So potassium levels will normally increase by succinylcholine, but the normal increase in succinylcholine, increase of potassium by succinylcholine, normal dose of 1 to 1.5 milligram per kg body weight is about 0.5 milliequivalents per liter. So that is not going to produce much problems, isn't it? So, but it can produce problems in certain conditions wherein the response can be a hyperkalemic response. So, what are the conditions where hyperkalemic response can happen?
Burns,
Burns. Okay.
crush injury.
Why in burns hyperkalemia occurs? Why in burns patient there can be hyperkalemic response? Why in burns? This is very commonly asked question for you.
Efflux of potassium.
No, why in burns there is a patient who has, suppose a burns patient after 3 months comes for, he has got a contracture to be released of the neck. You don't use succinylcholine.
Yes, sir.
Why? Because whenever there is burns are there, usually about 8 to 10%, more than 8 to 10% of deep burns, there is going to be a formation of extrajunctional receptors.
Transjunctional receptors.
This is called as denervation supersensitivity. Denervation supersensitivity. Normally, you don't have extrajunctional receptors. You have only junctional receptors. Whenever there is a denervation of the muscle fiber occur, so it's a protective mechanism. It increases the number of receptors, which is called as an upregulation of receptors, otherwise called as denervation supersensitivity of the muscle membrane. There will be a lot of extrajunctional receptors, plus the number of receptors over the muscle membrane also will increase. There will be a formation of receptors in the muscle membrane. These are called as alpha 7 receptors. So extrajunctional receptors, you know the difference. Extrajunctional receptors are otherwise called as fetal type of receptors, where you have a gamma subunit replacing
the epsilon
subunit. They are extrajunctional receptors. Plus, there are lot of receptors are formed over the muscle membrane. These are called as alpha 7 receptors. Because there are so many receptors all over the muscle membrane and also extrajunctional receptors. So these receptors are not acted upon by non-depolarizers. They are extremely sensitive to succinylcholine. They are even sensitive to choline, because succinylcholine will gets metabolized to succinyl monocholine and choline. Even choline can interact and open these receptors. And you can imagine the amount of potassium that can come out from inside the muscle. Inside the muscle cell, what is the amount of potassium that is present? Intracellular potassium levels, how much?
3 to 4.
No, extracellular potassium is 3 to 5 milliequivalents per liter. How much is intracellular potassium level? Potassium is basically an intracellular cation or extracellular cation?
Intracellular.
It is basically an intracellular.
Basically intracellular.
How much is intracellular potassium levels?
1.
Normal physiology, man. These things should always answer these questions. It is nearly 150 milliequivalents per liter. 150 milliequivalents per liter is intracellular potassium. Can imagine how much of this potassium can come out, because so much of depolarization is occurring all throughout the muscle membrane, extrajunctional, and then again over the muscle membrane. Suddenly there is a rapid influx or efflux, I can say, efflux of potassium from intracellular to extracellular compartment, sudden increase in the potassium levels, hyperkalemia, and the patient can end up with arrest, cardiac arrest, isn't it? So that is why in the burns patient, especially deep burns, more than 8 to 10%, you have to be extremely careful from what day to what day. You have to be extremely careful.
So up to
2 days,
200
from 2 days to 2 years.
Yeah, after 24 hours, up to 2 years. Some books say 6 months, but majority of the books now say that up to 2 years, it is better to be careful and better to avoid succinylcholine, because you have got a better drugs. Procronim is there. You need not have to use succinylcholine. So definitely you avoid succinylcholine in patients with burns, because the formation of extrajunctional receptors, because the denervation supersensitivity. Okay, one is burns. What are the other patients?
So prolonged ICU stays.
Okay, immobilization, prolonged immobilization.
Uh,
Okay, patients who are prolonged immobilized patients, again, there can be formation of extrajunctional receptors, right? Then
crush injuries, spinal cord injuries,
upper motor neuron palsy
upper motor neuron palsies,
and lower motor neuron palsy.
neuron palsies,
Like hemiparesis is there,
fibrillation,
hemiparesis, paraparesis, paraplegia, hemiplegia, all these patients. Hemiplegia can be upper motor neuron palsy. Paraplegia is a lower motor neuron palsy. So in these patients with hemiplegia and paraplegia patients, how long you should not use? Because burns patients, I told up to 2 years it's fine. Sorry, after 2 years it is fine. But in hemiplegia patients and paraplegia patients, when you can use succinylcholine? When you can use it? Say, hemiplegia has occurred 5 years back. Patient has partially recovered. Or a paraplegia patient, say 10 years, paraplegia patient. Can I use succinylcholine? If I
Complete
do a
recovery of
hospital-
palsy.
Pardon?
Complete recovery of palsy.
The complete recovery is very rare, isn't it? There will be some amount of motor blockage, maybe even a grade 4 motor blockage will be there. A paralysis will be there. Lifelong, you don't use. If there is no recovery and if the power is less than 5/5, you don't use succinylcholine at all in these patients. If there is still some amount of paralysis is there, you don't use. Okay, so upper motor neuron palsies, lower motor neuron palsies. Again, lower motor neuron palsy, another condition is GB syndrome, Guillain-Barré syndrome, post-inflammatory neuritis of the spinal cord. So, what about GB syndrome?
there will be down regulation.
No, GB syndrome is a lower motor neuron type of palsy. Spinal cord is involved. Upregulation. It's a same thing, denervation supersensitivity. So, but GB syndrome is self-limiting many times. The patients will completely recover. Once the patient is completely recovered,
Word we can use.
afterwards, if he has got, motor power 5/5, you can definitely use.
Yes.
I still remember when I was a postgraduate, there was one child with GB syndrome, just about, I still remember the child's name also, Markandeya was the child's name, 5-year-old child. Actually, from a poor family, these people had come for labor, manual labor from another place in Karnataka. They had come to Mangalore. And unfortunately, the child had developed. And the child was in ICU. This is almost nearly 38, 40 years back when I was a postgraduate. So it was recovering very well. So every one of us were involved. Anesthesia department, the pediatrics department, everyone, even the nursing department, we were all, hoping for the child's recovery. So unfortunately, after about 22 days, the child was recovering well, pulled out the. We had to re-intubate the child. I was not there actually, though I was a postgraduate, I was not there. I was not on duty. So unfortunately, another postgraduate had given succinate for intubating the child in the eyes. Immediately, the child had developed cardiac arrest, died. The knowledge, proper theoretical knowledge is so important, isn't it? If you had known that this child has got GB syndrome and still not completely recovered, if you had not given succinylcholine, the child would have survived, isn't it? So that is why I just wanted to tell you about this incident. In a child with GB syndrome, don't give succinylcholine. So lower motor neuron palsy. So that is another indication, sorry, contraindication for succinylcholine. Hyperkalemic response. So what are the other conditions wherein crush injury you said? Why in crush injury you should not use succinylcholine?
Same extra junction.
No, there is not the extrajunction receptor problem. Crush injury, muscle injury will be there. When a muscle injury is there, already there is increased potassium that is already there, and giving succinylcholine further increase the potassium level. So again, crush injury, you have to be extremely careful. Another contraindication is severe abdominal infection.
Abdominal infections.
So again, especially the abdominal infection also has the patient having metabolic acidosis. Metabolic acidosis with hypovolemia. These are the patients you have to be extremely careful with giving succinylcholine, because metabolic acidosis, any acidosis, the potassium moves from intercellular to the extracellular compartment. That is normal. So you have to treat potassium levels before, or you treat acidosis before giving succinylcholine for these patients with severe abdominal infections, metabolic acidosis, and hypovolemia especially. Because here it has been said that potassium will be released from the intestines. In such patients, if you give succinylcholine, and sudden hyperkalemia can occur. So again, you have to be extremely careful in such patients. Okay. What are the other conditions where succinylcholine you have to be extremely careful about?
Muscle dystrophies.
Yeah, muscle dystrophy. Yeah, very good. So in muscle dystrophy, especially, many of these children with muscle dystrophy, or even patients later, again, you can have rhabdomyolysis can occur in these patients. Myopathies, there is a problem is, if there is not this problem is not because the denervation supersensitivity, but succinylcholine can produce rhabdomyolysis. Myolysis, the sudden, so many muscles fibers can, die and then can release a lot of potassium because of the rhabdomyolysis, and especially Duchenne muscle dystrophy. Again, you have to, it's absolutely contraindicated. That's why, you must have seen many times when you read the succinylcholine vial, there is a black pearl caution is there in many of the succinylcholine vials, not to use succinylcholine in male children less than 8 years. Why that black pearl caution is there?
Because we will not know if the child has any muscular dystrophy. We wouldn't have evaluated.
Very good. Why male children? And
male
why
childs are more prone for dystrophies.
No, because the gene is carried by females, X chromosome, and disease is manifested in male children. Disease is not manifested in female children.
Females.
Because they carry.
Carriers.
It is carried in X chromosome. So these children, male children. And why 8 years?
That's a huge.
Because the clinical manifestation starts after it. Though a Duchenne muscle dystrophy is already there, for the child may be carrying that gene, the clinical manifestation usually starts after it. That is why the black pearl caution is for these children, less than 8 years, male children. You should be careful. If you can avoid using succinylcholine, better to avoid. But if you have to give, you have to be careful. That is what is very important. There's still a lot of things to be discussed about succinylcholine, especially the management of hyperkalemia and also the children. What are the other side effects of succinylcholine? Now, shall we continue tomorrow?
Okay, sir.
We'll continue tomorrow about succinylcholine side effects, other side effects. Then we go for non-depolarizers and neuromuscular junction monitoring, and then the reversal agents. Tomorrow we'll finish all those things.
Yes, sir.
Okay.
Reversals.
So reversals.
Actually,
reversal
we've been splitted.
agents,
We've been given only muscle relaxants.
Okay.
So monitoring and
If we
reversal
can
is
finish
like
the neuromuscular blocking agents, non-depolarizers also by tomorrow in 1 hour. So the other two, the next batch can discuss with me about reversal agents
Okay,
Yes.
sir.
tomorrow only.
okay, sir.
Okay, sir.
Right. Who will be there for
So
reversal?
Mona and
It's
Varshini, sir.
Mona and Gokula Varshini, sir.
Okay, okay. Then any doubts regarding today's discussion? Anything you have not understood? So in the chat box also there is not much. Any doubts regarding today's discussion? We had a good discussion today.
Yes, sir.
So any doubts regarding today's discussion? Anyway, tomorrow we have
Yes,
time for first 5-10 minutes.
yes, sir.
Discuss regarding the doubts. If you have, if anybody has, you ask all your friends about any doubts. So you can come out with all those doubts and we can discuss tomorrow first, and then we can go for NDM for
Yes, sir.
continue with scoline and then non-depolarizing muscle.
Yes, sir.
Okay, Jasvi and Siddharth.
Thank you, sir.
Thank you, sir.
Right.
Good evening, sir.
Good evening, sir. Thanks.
Yeah, right. Bye.
Thanks.